So I'd now like to invite Aoife Reid, Head of Edge Programmes and Clinical Career Progression, Vets Now Limited. Thank you, Aoife.
Thanks, Julie. Hi, everybody. Just a short introduction. I work for Vets Now, a primary care emergency service based in the UK that has about 60 clinics across the country, and Vets Now is part of IVC Evidensia. So my work primarily is with early career and mid-career vets, usually 2 to 10 years post-graduation. And they often say to me that they don't know if they're doing a good job or not, and they're unsure how to utilise their CPD provision. Their perception, although their clinical coaches may disagree with this, is that they receive limited structured feedback, and this is often coupled with the absence of systematic assessment unless they're pursuing a formal qualification like a certificate. Developing a formative tool supporting those vets to reflect on and plan their development beyond their vet GDP years could have lots of benefits for the vets themselves, their mentors, and their organisations. And for me, it would align with the contextual competence layer of Ola Tenkata's that he described so eloquently earlier. The idea I'd like to pitch to you today, it's not innovative and it's not expeditionary. It's based on a project that's already underway in the messy backdrop of primary care emergency practice. And this is a place where three-letter acronyms are more likely to be GDV, RTA, or DKA, rather than ILO or EPA. There, I'm exploring how the use of a modified competency framework could help to serve as both a mirror and a map for veterinary surgeons. I've adapted an existing open standard competency framework, which was first developed for emergency veterinarians by Julie Noyes. It was published by Julie Noyes et al. 2021 in JVAC. And that group identified 4 core competency areas, so patient care, interpersonal skills and client communication, professionalism and practice-based learning. My adaptation acknowledges the context of primary care emergency vets in the UK, and it also incorporates surgical proficiency and elements of the RCVS Code of Conduct related to emergency services. Rather than milestones, I chose EPA-style descriptors to help chart progress from have limited experience and can observe only right through to can model for less experienced vets. So my idea is that for individual vets, this would provide a scaffold for self-assessment, for new starts at induction stage to self-assess themselves and perhaps share with a clinical mentor where they felt they needed development. And for more seasoned, experienced vets, a way to chart their development, but also identify areas of skills decay. If they shared this assessment with their mentors or even with the wider organisation, then this could really provide valuable data points, as well as sparking dialogue and guiding support. And ultimately, if shared with the wider organisation, it could identify training needs on a broader scale and inform strategy. Early piloting of my framework using an anonymous cross-sectional survey has, I think, provided some really interesting insights. So we had over 100 emergency vets and 75 stakeholders fill in this survey. And one of the things that I found most interesting was areas where vets identified themselves as highly skilled, yet their stakeholders felt there was still room for development, and vice versa. There were areas where they were congruent and areas where they diverged. And I say this really not to judge, but to cultivate how we can bring and align both of those together. One limitation, I think, with using a competency framework in this way is that for honest self-reflection, it does require some vulnerability and also psychological safety. However, having a defined structure may create transparent conversations, and that may strengthen trust between individuals and organisations. So to end, I'd like to ask you to consider the benefits if both vets and mentors aligned around a single structure that was formative, designed for lifelong learning, and not as a cage or a tick box exercise, but more like a tree. Thank you for your attention. We have an extraordinary amount of expertise on this topic in the room, so in true corporate style I may outsource during the Q&As, if that's okay. But yeah, looking forward to your insights and comments.
Thank you. Do we have any questions or comments, or does anybody want to open any discussion on this topic? Oh, we've got a question over there towards the back. Thank you.
Hi, I just wondered if there would be any sort of stratification to the competency framework based on like years qualified, things you should be aiming at earlier and later and so on.
Yeah, I think that's more in the descriptors, I guess. So for me, it would be lifelong, and I guess that continuum would depend on their previous experience. And my experience when I meet these people 2 years post-graduation is they're all at different levels. And so this allows them to plot where they think they are and where they might want to get to. And so I think rather than a time, it would be based on their skills at that moment that they do it. And although the initial work that I've done was cross-sectional, I have done a little bit of longitudinal work, which is ongoing at the moment. And I think that's going to be really valuable to see how people chart over time.
I think it's a great idea, by the way. It just fills a real niche where you drop out of formal education, and it's that awkward bit in the middle. So yeah, great idea. Thank you.
We've got a question over on the left there, Jenny. Thank you.
Hi, thank you for presenting this. I spent many years in equine ambulatory practice, and at a very, very basic level, we used to do something similar with new joiners, just to help identify areas where they felt that out in the field they might need support, and that support isn't often forthcoming when you're driving around in a van on your own, seeing a colic in the middle of the night. And we actually used it to help guide our receptionists and triage nurses at point of contact with the clients, so that they could identify that they were sending somebody out to do a procedure because perhaps they were the closest and they would get there in the most timely manner, but to flag that to them so that they could say to the more senior staff, this person has gone to a serious colic, let's say, and they're, we know that they're not going to be confident in placing a nasogastric tube because they've never done it before. Could you head that way now, rather than waiting for the problem to arise when the clinician got there and found that they were out of their depth? So I think having a more detailed structure like this would be really helpful. And then what you've just said there, building upon that for later on in your career to self-reflect and hold a mirror up and say, where am I actually at, and where do I need to focus my time and money and CPD budget to help my business grow, but also for my personal development. So yeah, just to commend you on what you've done. Thank you.
Thank you. I think from my point of view, I think probably a lot of organisations do this really well at induction, but then I think it sort of disappears then. And so what I wanted was something that had more life in it and longevity, and that you could chart it over time. And also, I suppose, as those skills could decay, because in emergency practice, specifically, I suppose there's things that we don't do very often, and so you may be competent year 1, but then you may not be competent year 6, and that will be different for every individual depending on their caseload. Yeah. Thanks.
Thank you. We do have time for one more question, if there are any other questions. No? Okay. Well, thank you, Aoife.
Thanks.
Thank you very much.